Hello guys, today we will talking about uh, your first lesson about hospital surgery, yeah, and 5 year education. I remember you. And first lesson on this year will be the syndromic approach in surgery and abdominal pain syndrome, or how we call it in old world acute abdomen. Um, Introduction. Acute abdomen is a condition that demands urgent attention and treatment. The acute abdomen may be caused by an infection, inflammation, vascular occlusion, or obstruction. The patient will usually present with sudden onset of abdominal pain with associated nausea or vomiting. Most patients with an acute abdomen appear ill. The approach to a patient with an acute abdomen should include a thorough history and physical exam. Quadrants of abdomen and uh, then understand that the location of pain is critical as it may signal a localized process. However, in patients with free air, it may present with diffuse abdominal pain. But I think you remember this from facultative surgery, where we tell you about this one. And we just repeat this moment. Uh, right hypochondria, gallstones, cholangitis, hepatitis, liver abscess, cardiac causes, lung causes, epigastric, esophagitis, peptic ulcer, perforated ulcer, pancreatitis, hypochondria, spleen abscess, acute splenomegaly, spleen rupture, uh, right lumbar or right mesogastrium, ureteric colic, pyelonephritis, umbilical, appendicitis, mesenteric epinitis, megazdenic diverticulitis, lymphomas, left lumbar or left mesenteric, ureteric colic, pyelonephritis, right iliac, appendicitis, Crohn's disease, second obstruction, ovarian cyst, ectopic pregnancy, hernias, hypogastric, testicular torsion, urinary retention, cystitis, placental abruption, left-sided diverticulitis, ulcerative colitis, constipation, ovarian cyst, hernias. Introduction. Auscultation may reveal absent vowel sounds, and palpation may reveal rebound tenderness and burden suggestive of peritoneus. The causes of an acute abdomen include appendicitis, perforated peptic ulcer, acute pancreatitis, ruptured sigmoid reticulum, ovarian torsion, volvulus, ruptured aortic aneurysm, lacerated spleen or liver, and ischemic bowel. Etiology. Common causes of an acute abdomen include acute appendicitis, cholecystitis, pancreatitis, and diverticulitis. Acute peritonitis is a cause of acute abdomen and can result from rupture of a hollow viscous or as a complication of inflammatory bowel disease or malignancy. Vascular events causing an acute abdomen include mesenteric ischemia and ruptured abdominal aortic aneurysm. Yeah, there you see a rupture aneurysm, and there you see mesenteric ischemia. Etiology. Obstetric and gynecologic causes include ruptured ectopic pregnancy and ovarian torsion. Etiology. Urologic conditions including ureteral colic and pyelonephritis can also present an acute abdominal pain. Many authors include small bowel obstruction as a cause of acute abdomen. I too. Newborns can present with necrosis and enterocolitis. Midgut volvulus present 40%, of the time in the first week of life, 50% in the first month, and 75% in the first year. Intussusception usually occurs at age 9 to 24 months. The most common cause of an acute pediatric abdomen is appendicitis. Remember this one. Epidemiology. No exact numbers are available, but between 7% and 10% of emergency department visits are for abdominal pain. The Centers for Disease Control and Prevention, using data from the 1999 through 2008 National Hospital Ambulatory Medical Care Survey, reported that 11% of emergency room department visits in 2008 were for abdominal pain, and that abdominal pain accounted for 12% of emergent or urgent patients. About one-third of abdominal pain patients are diagnosed with non-specific abdominal pain. Another 30% have acute renal failure. Pathophysiology. The pathophysiology of each disease entity is beyond the scope of this review. Causes include infection, like appendicitis or diverticulitis, and obstruction, appendicitis, cholecystitis. Anatomic abnormalities include malrotation of the gut. Age is associated with some disease. Older patients are more likely to present with diverticulitis, cholecystitis, and vascular emergencies. Pathophysiology of the nerves. The classic presentations of appendicitis, cholecystitis, pancreatitis, and diverticulitis are in large part the result of the dual innervation of the nerve, both visceral and somatic. Visceral nerves are part of the autonomic nervous system and innervate the viscera. These nerves are sensitive to mechanical distension, inflammation, ischemia, and the intense, smooth muscle contraction seen in colic. The pain is often midline, poorly localized, deep, and dull. Pain from embryonic foregut structures such as the stomach, liver, pancreas, and gallbladder radiate to the epigastrium. Midgut structures, small bowel and appendix to the periumbilical area, and hindgut, large bowel and rectum to the lower abdomen. Somatic sensory nerves provide sensation to the parietal peritoneum. Somatic pain is sharper and better localized. Somatic pain suggests peritoneal irritation. An example is a pain over McBurney's point when the inflamed or ruptured appendix is irritating the parietal peritoneum. Because visceral and somatic afferent nerve fibers share spinal cord segments, visceral pain can be felt as referred pain from a somatic distribution. This explains cholecystitis relation to the right scapula. The history and physical exam serve to eliminate some diagnoses and suggest others. Acute care physicians are well aware of the models of presentation of this disease and types. The immediate onset of pain suggests a vascular event such as mesenteric ischemia, syncope hints and blood loss as from a ruptured ectopic or leaking abdominal aortic aneurysm. Various causes of an acute abdomen have classic periton presentations. Appendicitis is supposed to start with dual periumbilical pain that migrates with time to the right lower quadrant. Avarian torsion is supposed to start with sudden unilateral lower abdominal pain that waxes and wanes and is associated with vomiting. Unfortunately, most diseases fail to present classically. A leaking abdominal aortic aneurysm can present exactly like renal colic or as apparently a benign low back pain. The clinician simply has to consider serious diagnosis in patients at risk. Pain in various quadrants suggests varying diagnosis. Acute diverticulitis usually lies in the left lower quadrant, while cholecystitis is usually felt in the epigastrium or right upper quadrant. Diagnosing a patient with a full-blown acute abdomen is easy. It is amazingly difficult to diagnose an insufficient abdominal catastrophe in a patient presenting with early non-specific symptoms. The past medical history can be important. Hypertension is a risk factor for abdominal aortic aneurysm. The social history regarding alcohol use and possible pancreatitis helps as well. The physical exams should be focused and completed in a timely fashion. Abnormal vital signs or the general appearance of the patient, including facial expression, skin color, and temperature, and altered mentation should alert the clinician that the patient may be in extremis. A complete abdominal exam is essential. Bowel sounds must be assessed. Palpation for messes, pain, burden, and rebound is important. Last teaching demands a rectal on every patient with abdominal pain. Literature suggests that rectal exam, at least in appendicitis, doesn't add any useful information. Certainly, rectal exam is important when gastrointestinal bleeding or prostate issues are suspected. A pelvic exam should be performed when a gynecologist source of pain is suspected. A young male with abdominal pain needs a testicular exam to exclude testicular torsion. Examination for hernia should be routine, and you need to do it for all your patients. Again, rapid initial diagnosis and treatment of the acute abdomen are crucial. Evaluation and treatment should be simultaneous. Diagnostic interventions include blood work and imaging. In adults older than 40, a 20 lead ECG can help exclude myocardial infarction as the cause of apparent severe abdominal pain. It is important to know if a patient with mesenteric ischemia is in atrial fibrillation. Usually, a complete blood count, comprehensive metabolic profile, and lipase are obtained. For sepsis or mesenteric ischemia, a lactate should be ordered. A urine or serum pregnancy test is needed in the workup of ectopic pregnancy. Diagnostic imaging has advanced rapidly in the past 3 decades. A bedside ultrasound in the emergency department can diagnose cholecystitis, hydronephrosis, hemiperitoneum, and the presence of an abdominal aortic aneurysm in less than 5 minutes. Diagnostic ultrasound is the preferred modality for cholecystitis, pediatric appendicitis, rupture, ectopic, and ovarian torsion. Multi-slice helical CT scanning has made the diagnosis of an acute abdomen much more straightforward. In the majority of cases, intravenous contrast is sufficient. Oral contrast is time-consuming and not usually necessary. MRI is not usually utilized simply because of the time required in a potentially unstable patient. Hypertension and tachycardia suggest blood loss, hypovolemia or sepsis and require prompt, aggressive fluid resuscitation with adequate large bore for access. Broad-spectrum antibiotics covering gram-negative enteric organisms should be administered in a timely fashion when infection, peritoneal soilage, or sepsis is in the differential. Yeah, and there you can find all antibiotics, all classes. Please remember this one. Sick patients should be monitored with ongoing vital sign resuscitation. Adequate pain relief with opioids is a standard of care. The use of antiemetics is likewise important. If a surgical emergency is suspected based on presentation or physical findings, a surgeon should be consulted in an emergent fashion. The surgeon must be contacted before potential time-consuming testing is performed. In summary, the acute abdomen consists of several intra-abdominal processes that require rapid intervention in both diagnosis and treatment. Or an acute abdomen may present in an obvious or subtle manner, but must always be recognized. Rapid, appropriate testing and concomitant resuscitative therapy are mandatory. If the condition is even possible surgical, early consultation with a surgeon is mandatory as well. And of course, differential diagnosis. There you can find all absolutely all disease for what you need to do a differential diagnosis. I don't will um, tell all this for you, but you see it and you know this disease. In general, the finding of an acute abdomen is indicative of a surgical problem, and in the past, the patient was taken directly to the operation room. Unfortunately, there are also some medical disorders that can present with acute abdominal pain that requires medical therapy. These conditions include acute pancreatitis, sickle cell anemia, diabetic ketoacidosis, adrenal crisis, and pyelonephritis. Today, ultrasound and OCT scans are widely used to determine the cause of acute abdomen so that the surgeon knows beforehand what to expect during surgery. It also avoids unnecessary surgery in patients with medical causes of an acute abdomen. All patients with an acute abdomen need to be seen by a surgeon. If the patient is stable, imaging studies can be obtained. If the patient is unstable, immediate surgical intervention may be necessary. The prognosis of patients depends on the cause. Complication. If left untreated, an acute abdomen may result in the following. We can have the sepsis, necrosis, and/or gangrene of bowel, fistula, and death. Postoperative and rehabilitation care. Since most patients with an acute abdomen are seniors, they are best managed in an ICU settings. Intravenous hydration, nasogastric decompression, and pain control are often required. The role of antibiotics depends on the cause. Close monitoring is required as patients may develop complications like atelectasis, ileus, wound infections, DVT, and pneumonia. Guys, thank you very much for your attention, and you will have more 6 lections. Don't forget about them, and don't forget about the Telegram channel. And see you on the next lecture. Bye bye.